What's going on, guys? This is Trace from STA Nursing, and today we're going to be covering ABGs, or arterial blood gases. And hopefully by the end of this video, you have a good comprehension of how to interpret these and what the main causes of some of these pathologies might be. So first, let's jump into the reference ranges, right? This is something that you're just going to have to memorize. I don't know if you're watching this video because maybe you're about to take the NCLEX or you're reviewing acids and bases in your class. I don't know why you're watching it. Maybe you're watching it for fun. If you are, welcome. Welcome to you all. But I'm going to have to tell you, you're going to have to memorize this chart right here, okay, if you want to be able to do anything with ABGs. Okay, so now that we got that out of the way, we can go into a strategical way of interpreting these and, always being right. Because I promise once you get it, you'll be kicking yourself for not knowing it. Because they're super simple, I promise. So we're going to jump right into it. And actually, one more concept I feel like it's important to understand is your acid, or what's going to lower your pH, right? It's going to be your CO2, right? So it's going to be an acid, which decreases pH. And your bicarb is going to be your base, which increases pH. And by pH, I mean the blood pH, because we're drawing these from the blood, remember? Okay, so this is your blood, your pH right here. This is your overall blood pH. And it can be high or low based off the amount of CO2 or HCO3 you have, aka HCO3 is bicarb. And the PaO2 will be important in real life and clinical practice, but for the purpose of this video, to interpret the ABGs, to be able to understand whether you're in a respiratory or metabolic acidosis or alkalosis, the PaO2 is really not relevant to the strategy I have to understanding these. But in real life, if you see someone's PaO2, which is your arterial oxygen, I have it in parentheses right here, that is important. You want to know that in real life. But like I said, for the purpose of this video, we're not going to use it. So the first thing I do to understand these is I look at the pH. The pH tells the story. It tells you whether you're acidotic or alkalotic, right? So in this, we know that our reference range for pH, number one, the reference range for pH is 7.35 to 7.45. So when we see a pH that's low, it is going to be acidotic, okay? Because I don't know if you remember from your 6th grade science class, but when it comes to pHs, the higher you are, the more basic, or aka alkalotic you are, and the lower the pH, the more acidic. So we look at that blood pH, it's in an acidotic state. Now the next step to figuring it out is going to be why. So let's look at our CO2 right here. Let's look at it. So 52. Well, let's look at our reference range, 35 to 45. So our acid, which lowers the pH, is high, aka our CO2. This is high. So what does that mean? That means it's going to, if an acid is high, it's going to lower the pH. And as we can see in the pH right here, it has lowered it, right? So I think we figured out our problem here is we have too much carbon dioxide in our blood. Now that'll be respiratory acidosis. And why is it respiratory? Well, here, let me go ahead and give you a little rundown if you don't already know. If you already know, you can skip past this. But CO2 is respiratory because our lungs, when we inhale, we are receiving oxygen from our environment. And when we exhale, we are getting rid of CO2 from our blood. So the capillaries from our blood bring that CO2 to the alveoli in the lungs to exchange that CO2 for oxygen. So basically, it's like a trade. We're trading our alveoli, or aka their little sacs in the lungs where oxygen comes in. We're trading that CO2 for oxygen. So we'll get rid of the CO2 in our blood. And here, let me just do a quick drawing of that, okay? Sorry, I know my drawing's going to be bad, but here's our little alveoli, and here's our little bloodstream right here. Okay, so in this bloodstream right here, we have a ton. I'm going to just use C's to represent CO2, but we have a ton. Here, let me do this real quick. We have a ton of CO2. So remember that C represents CO2. And in the capillary, or not capillaries, in the alveoli right here, that little that black ball, when we inhale, we get a bunch of oxygen, which I'm going to represent, not yellow, which I'm going to represent as green. We have O2. We just get a bunch of oxygen particles in our lungs when we inhale. So when we inhale, we get oxygen. And what's happening is the red blood cells that carry this CO2, let's see, I'll draw a little. So there's a little red blood cell. There's a little red blood cell. The red blood cells are what carry that CO2. And whenever we inhale, we're trading that CO2 for oxygen. So we're doing a little trade right here. Okay? And if you don't understand where we are in the body right now, I would highly recommend you look up lung anatomy and look up, basically look at the alveoli, because that's what we're looking at. We're looking at one alveoli sac right now. So we're trading that CO2 for oxygen. And so then the CO2 is going to move into here, the alveoli. And when we breathe out or exhale, we're getting rid of that CO2. Okay, so hopefully that gives you a good understanding of what's going on in the body here. So we have high CO2, which we know that's an acid. That means we're in an acidotic state right here, respiratory acidosis. Hopefully you understand, and the bicarb in this example is normal. It's within the reference range. So we know that's not the problem. Okay, next problem. Okay. So, first thing we look at, the pH. What does it tell us? The pH will tell you the story. So, 7.5, that's above the normal range, right? So we already know before we look at any numbers, we're in some sort of alkalotic state. Now we just got to figure out why we're there. So when we look at the CO2 right here, 25 to 30 or 35 to 45, we know that CO2 is not in the reference range. In fact, it's low, which would explain our alkalosis, right? Because we're losing acid, so the blood pH is going to rise because we're losing acid. And acid, if we have acid, it's going to bring down the blood pH. But when we lack it, it's going to raise the blood pH. Okay, so we don't have enough acid to lower the pH, so it's going to be respiratory. And anytime it's CO2 is the problem, it's going to be respiratory, because that's our primary way of expelling CO2. So respiratory alkalosis is that. Let's move on to number 3. So number 3, we look at the pH. What do we got here? We got an alkalosis of some sort. We already know because we look at the pH, right? So alkalosis. Now let's look at the CO2. CO2, the range is 35 to 45, as you can see in the reference range right here. Oh, don't do that. Right here. Sorry, that's bad. So that's normal. We know the CO2 is not the problem here. Let's look at the bicarb, our basic component of our ABG. It's a little high, which, looking at, since we're in an alkalosis state, that would explain it. And so CO2, like I said, kind of represents respiratory, and bicarb represents pretty much the rest of the body, at least for the ABG purposes. So if it's not respiratory alkalosis, it has to be metabolic alkalosis. So let's go ahead and write that. Metabolic alkalosis. And that's the first 3 problems. Now we're going to move into the part where people really start to get confused about whether it's partial, full, no compensation. All right. Now let's look and see whether it is fully, partially, or not compensated, all right? And it's really simple. I promise, once you get it, you'll get it, okay? So, first, what tells the story on whether a blood gas is compensated or not is, first, you're going to want to look at the pH. Is the pH within normal range? 7.45? Yes, that is within normal range because it's 7.35 to 7.45. So it's going to be fully compensated. And I'm just going to abbreviate that real quick for the lack of room I have. Okay? So now that we know it's fully compensated, we got to figure out the problem here. Now, in real life, in clinical practice, there might not always be a problem, right? But for the purpose of like your unit exam or NCLEX, there might be a problem. Okay, so we're just going to try and figure out why this pH is more on the, yes, it's within normal range, but it's more on the alkalotic side. So let's try and find a blood gas reading that would tell us what makes things more alkalotic. You're either high bicarb or low CO2. Okay, so let's look. Our bicarb, it's looking a little high. So right now that is looking like our problem. And the CO2 is also high, which our CO2s are acid. So that being high, that's more of an acidotic rather than alkalotic. So we know that the problem here is that our bicarb is out of range. Okay? So it's going to be metabolic alkalosis with full compensation. Okay, so we're going to do that right there. So let's look at the next problem, okay? So we look at the pH to see whether we have any compensation at all. 7.2. Is that within the normal range? No, it's not. So we know right away that there is no chance it's fully compensated because it's out of the normal range, the blood pH that being. Okay, so now let's try and figure out why it's more acidotic than alkalotic. So let's go ahead and write acidosis, because we know, like from what I said before, we look at that pH. If it's low, we know it's acidosis of some sort. Okay, so let's figure out the problem. Boom, we look at CO2. There's our problem right there. The range for CO2 is 35 to 45, and ours is 55. So we know that is the problem right there. So we're going to go ahead and write respiratory acidosis because we found our problem. And how we tell the partial compensation, this is how we can tell, okay? So let's say in this instance, the bicarb is within normal range, okay? So it is considered no compensation. But let's erase this. Let's say this bicarb was 29, which we know it only goes to 26, so it's out of the normal range, right? The bicarb is higher than normal, so we can tell that it's trying. It is trying to fix this 7.2 blood pH because it's basic. So the more bicarb we have, the higher the pH is going to go. So it is trying to fix that blood pH. So we can give it partial credit because it hasn't fixed it, but it's trying. So we're going to say with partial compensation. Okay. So it's getting like partial credit like you might get for an assignment because it didn't do all the work, but at least it tried to fix it, right? Okay, let's look at another one. So boom, we look at the pH. Is it within normal range? Yes. So we already know that it's fully compensated just by looking at that. And is it more from the range of the pH, 7.35 to 7.45, is it on the lower or the higher side? It's on the lower side. So we're going to know that that's an acidosis of some sort. Now we just got to figure out what sort of acidosis, whether it be respiratory or metabolic. So let's look at our CO2. Ooh, that's looking a little high, right? And our bicarb's high too, which the bicarb is our base and the CO2 is our acid. So if we have a high acid and we're also in an acidotic state, odds are that's our problem. So what's our problem? Our CO2. So it's going to be respiratory acidosis with full compensation because our pH is within the normal limits. That means it's fully compensated. All right, guys, that's it for this. Now I'm going to jump into, all right, guys, let's get into some of the common causes for some of these pathologies. So, respiratory acidosis. What would be a normal cause of this? Well, mainly, so anything that's going to cause you to hold on to CO2 is going to cause respiratory acidosis. So it could even be as simple as just hypoventilation or bradyapnea. All right, so anything just causes slow breathing because think about it, you're not releasing that CO2 as fast as you should. So it's going to cause you to hold on to that CO2 because you're not exhaling. So it's going to cause an acidosis because you have an excess of CO2. What else can cause it? Something like a pneumothorax, right? Why would a pneumothorax cause acidosis? Well, think about it. You puncture your lung, right? There's a hole in your lung. Air is leaking into your chest cavity. Okay? And that air includes the CO2. That CO2 is a gas. Okay? So that CO2 is going to leak into your chest cavity and not out of your mouth from your lungs. So you're going to hold on to that CO2, which is going to cause acidosis. So basically any cause, COPD, right? Asthma and asthma exacerbation. Anything that would cause you to hold on to CO2 would be a cause of respiratory acidosis. Now, respiratory alkalosis is pretty simple. The main cause is hyperventilation. Okay, like I said earlier, if you are letting go of CO2 rapidly, like you are getting rid of the CO2 faster than the body makes the CO2, and we need a little bit of CO2 to maintain homeostasis within the blood. So hyperventilation is going to be your main cause of respiratory alkalosis, and that could include things like anxiety, just nervousness, anything that's going to cause you to breathe more than your body can create CO2. Now, you might think exercise, possibly, but typically in exercise, there's something else that makes up for that CO2 loss and maintaining the acidic balance of the blood, and that's your lactic acid. Okay, but don't worry about that. Just know hyperventilation is the main cause of alkalosis. Now let's jump into metabolic acidosis. What is the main cause? So your main things that are going to cause metabolic acidosis, well, pretty much anything that isn't respiratory, right? So your diarrhea, funny enough, is going to cause metabolic acidosis because think of it like this. Base comes out the bottom. Okay, this is a little thing that my teachers taught me. Okay, I don't know why I wrote that. Base comes out the bottom, as in your rectum. So when you poop, there's a lot of bicarb in your intestines. And when you're having diarrhea, you're washing that bicarb out. So you're going to have, in metabolic acidosis, you're just going to have a decrease in bicarb. Okay? Now, there are a bunch of other causes, but for the ABG purposes, it's going to be a decrease in bicarb. And metabolic alkalosis. Now, this one's also pretty simple. Vomiting. And the reason vomiting causes metabolic alkalosis is because when you're throwing up, where does your throw up come from? It comes from your stomach, right? And this RT means related to. So you're losing stomach acid. So once you lose a bunch of acid, just like when you breathe too fast, you're going to be in an alkalotic state. Okay? So there is a good comprehension of ABGs. Hopefully this video has helped you understand ABGs, maybe be able to interpret them or know what's going on in the body in these certain pathologies. I appreciate y'all watching, and hopefully I see